Hi, my name is Jay Jones, and we're here to talk about intraoperative EMG, methods, utility, and alarm criteria. First, a little bit about me. I'm an IOM specialist at Global Monitoring Inc. and also currently teach the Neurodiagnostic Technology program at Concord Career College in San Bernardino, California. I'm registered in EEG, EP, and I have my certification in intraoperative monitoring and nerve conduction as well. To be brief, the scope of this lecture is just to provide an introduction to intraoperative EMG monitoring, and we will not be discussing advanced monitoring methods. So what is EMG and why do we monitor it? EMG, or electromyography, is a recording of spontaneous or elicited electrical activity of muscles. Changes in EMG recordings are indirect indicators of the function of innervating nerve roots, and the intraoperative use of EMG includes localization, assuring the integrity of peripheral nerves, and ensuring proper placement of instrumentation. Nearly any muscle can be monitored from face to foot. EMG is continuously recorded with the differential amplifier, and recordings are displayed visually to the tech and can also be connected to a speaker to provide auditory feedback for the surgeon and also the reading neurologist. This lecture will discuss methods and application of intraoperative EMG. However, we will avoid talking about cranial nerve monitoring, as that has been covered in another lecture. Because SCPs cannot evaluate nerve roots, because the stimulated axons arise from the dorsal root ganglia of multiple spinal levels, we use EMG. Typically, the nerve roots and not the peripheral nerves themselves are at risk during spinal procedures. Therefore, EMG should be utilized. In procedures requiring specification of neural structures, such as selective dorsal rhizotomies, thyroidectomies, among others, EMG can be used to identify specific nerves or nerve roots when placing instrumentation such as pedicle screws that a surgeon may require triggered EMG to ensure screws are properly seated into the vertebrae. So electromyography may be recorded as either spontaneous, which may be called free run, or triggered myogenic potentials. Free run is a very passive way of monitoring EMG. It's just monitoring any activity that the muscles may receive from the nerve roots, whereas triggered EMG is an active recording method where we are actively stimulating nerves and recording the responses from their innervated muscles. Spontaneous or free run EMG activity does not ensure the integrity of the peripheral nerve, but does allow real-time monitoring of the nerve root activity. Direct electrical stimulation of the nerve can help localize neural structures. And if evoked or triggered EMG activity can be elicited consistently, integrity of the nerve and muscle distal in relation to the stimulation site can be assured. These are some of the tools of our trade here. Subdermal EMG needles are typically placed under the skin at the muscles to be examined. EMG may be recorded with surface disc or cup electrodes. However, needle EMG electrodes are much more commonly used in IOM, as they provide for faster application as well as secure application. Although the needle electrodes have less surface area to record with, impedances are typically lower because they're placed subdermally, and they're usually better balanced as well. The montages that we use can be configured in many different ways. Bipolar EMG montages utilize 2 recording electrodes in the same muscle. Bipolar chained montages will chain multiple recording electrodes, like a bipolar EEG montage. This may be used to save channels or resources if you're using a machine that doesn't allow you to use as many channels as you might need for a particular surgery. Referential montages utilize one active recording electrode in the muscle, and that's referred to an inactive electrode, usually near a bony area. Amplifier and filter settings can be seen here. Filter bandpass is usually between 30 and 30,000 or 30 and 3K hertz. Display gain 15 to 50 microvolts per division. And the time base can depend on what you are actually monitoring and why you're monitoring it. For example, free run EMG is probably best monitored at about a 5-second time base. This is very similar to EEG for those familiar with EEG, and allows you to see a more complete picture of the EMG firing and still give you time to store it before it disappears. In triggered EMG, since we're looking for time-locked responses, we use shorter time bases like 10 to 100 milliseconds. Free run or spontaneous EMG is useful for monitoring specific nerve root functions. So free run EMG is monitored by using subdermal needle electrodes that we saw earlier, placed at the specific muscles innervated by the roots of importance. Spontaneous or free run EMG is the more passive method, as we've discussed, similar to EEG because the myogenic potentials are being recorded as they happen instead of being seen in a time-locked manner. As far as alarm criteria goes for free run EMG, we're looking for a specific firing such as bursts or train firing. These phasic burst patterns consist of single or repetitive, asynchronous, often complex and polyphasic morphological pattern potentials, usually indicate irritation of the spinal cord or nerve roots. Train firing or tonic activity consists of prolonged, multiple, repetitive, synchronously grouped motor unit discharges, which can last for a few seconds or even several minutes. Train firing often indicates neural damage. So for free run EMG, what would we use it for? A lot of times we, again, use it just to monitor the nerve roots. And here's a few examples of some of the procedures that we use free run EMG in, and also some of the basic muscles that we may use to monitor free run EMG. So for cervical procedures, there are many muscles that we can monitor cervical roots from, but we're just going to give a few examples here. This is far from a comprehensive list. On this list, we see trapezius sternocleidomastoid for nerve roots in C2, 3, or 4, the cervical plexus. And we see bicep deltoid for C5, 6, C6, 7, flexor carpi radialis, and abductor digiti minimi quinti, the 5th digit. Again, not a comprehensive list. Just a little note also, there is no data on the utility of EMG from trapezius muscles. They also have a high rate of false positives. So they may be monitored, but the usefulness of trapezius EMG is in question. So now we're going to go over a few examples of placements. Here for the deltoid muscle, you can see that it is the abductor muscle right at the top of the arm at the shoulder. And the deltoid muscle can be used to monitor C5 and C6. The biceps brachii can be used to monitor C5 and C6 as well. And this is just on the anterior of the upper arm. On the forearm, we may use the brachioradialis as well. The triceps can also be used to be monitored for cervical procedures. Triceps, specifically the medial or long head of the triceps, are particularly useful for monitoring C6, primarily C7. But it also does get a little bit of innervation from the C8 nerve root. But C7 would be primary when we are monitoring from the long head of the triceps. The flexor carpi ulnaris muscle can be used to monitor C8 or T1. And the abductor digiti minimi quinti can be used to monitor C8 down to T1. For thoracic procedures, EMGs often declined, but this is because of the non-specificity of muscles innervated by thoracic nerve roots. In cases where these nerve roots need to be monitored, the following muscles, among others, can be used. Muscles like the upper rectus abdominis, middle, lower, and inferior rectus abdominis as well. In this illustration, you can see different areas where the needles would be placed. Other muscles like intercostal and oblique muscles may be used. However, these muscles are deeper and would require longer needles. And then there would be even less specificity because you may also get activity from the more surface muscles. For lumbosacral procedures, there's a lot of muscles that we have the option of monitoring here. So keep in mind, many of these placements will also be used for pedicle screw placement and testing, so they can pull double duty. Following are several sites that may be used. We can use any of the quadricep muscles like vastus medialis, vastus lateralis, rectus femoris, and vastus intermedius. All are innervated by the femoral nerve at L2 to L4. The tibialis anterior and peroneus longus can be used to monitor from L4 to down to S1. Gastrocnemius S1-2, and on lower sacral procedures, such as the tethered core procedure, we can monitor the external anal sphincter. Some examples of needle placement for the quadricep muscles, which are really ideal for monitoring anything from L2 to L4. These are on the anterior portion of the thigh. Also, if you need to monitor higher levels such as L2, we can monitor muscles like the adductor and iliopsoas muscles. Tibialis anterior can be used to monitor L4, L5. This muscle is just lateral to the tibia. Pretty easy to find. Peroneus longus muscle can be used to monitor L5 to S1. This one might be a little more difficult to find, but it's pretty easy if you just find the fibular head on the lateral aspect of the leg just below the knee, and then go down about 3 or 4 finger widths to find a proper place on the muscle belly. The gastrocnemius muscles may be used to monitor S1 and S2. And there's no preference between medial or lateral gastrocnemius. For triggered EMG, again, this is an active recording method performed similarly to motor nerve conduction studies, where we're stimulating in one part of the nerve, and then we're recording the motor potentials that are distal to that nerve. Subdermal needle recording electrodes are placed at the muscle site, and a stimulator applies a current to the surgical instrument or nervous tissue, and a time-locked evoked response is recorded. This may be used for nerve mapping or testing instrumentation, such as pedicle screws. When talking about triggered EMG, it's important for us to know the CMAP. The CMAP is the compound muscle action potential. The action potential we're recording at the muscles. This CMAP is going to be elicited when we reach the stimulation threshold for these nerves. So the threshold is the stimulation level at which CMAP is produced. The CMAP itself is summated activity of the synchronously activated muscle fibers from a particular muscle when stimulated along its motor pathway. Typically seen with direct nerve stimulation under 2 milliamps, and with screw testing The thresholds can really vary based on the stimulus and recording parameters, but typically should be seen above 7 to 10 milliamps with well-placed screws. We may use mono or bipolar constant current stimulation. The intensity is typically started at 0 and then increased until we reach the threshold for the CMAP. And stimulation rates may vary between 1 to 5 hertz. Duration is usually short, 0.2 to 0.3 milliseconds. And it's also very important that we make sure we have a train of 4 showing 4 out of 4 twitches. That's not always going to be the easiest case in the OR, as a lot of us know. So there are some variances, but 4 out of 4 would be ideal. And pedicle screw placement. Properly placed screws that remain entirely within the bone have a very high impedance. That bone is impeding the electric current from spreading out to neural structures. So if the screw is stimulated with stimulation greater than 10 milliamps without EMG activation, the screw is unlikely to have breached the vertebral cortex. However, response to stimulation at less than 10 milliamps may suggest a bony defect that provides low impedance pathway to the nerve root. The use of pedicle screws as a fixation device in posterior spinal instrumentation in the lumbar region has become increasingly common. Various methods to assure correct placement of the screws are advocated currently. EMG monitoring makes use of the fact that improperly placed screws that breach the cortical confines of the bony pedicle or vertebral body cause low impedance between the screw and the exiting nerve root underneath the pedicle. Other methods that can be used besides just stimulating the screws after their place include navigation that uses CT imaging and registered instruments using technology pretty similar to motion capture. And of course, the tried and true method of fluoroscopy guided screw placement. With tethered cord release, patients undergo a tethered cord release procedure required dissection of scar tissue and possibly section of the filum terminale. Distinguishing functional neural elements from non-functioning tissue is very important. Stimulation of the roots of normally functioning nerves in the cauda equina elicit EMG activity, and monitoring lower extremity musculature as well as anal and urethral sphincters is important if the sacral roots are involved. To monitor the anal sphincters, you would place bipolar EMG needles on each side of the sphincter so that you can monitor left and right side. With selective dorsal rhizotomy, this is a similar procedure in which we use it to reduce debilitating spasticity in conditions such as cerebral palsy and selectively transecting spinal rootlets. Overactive excitatory influence on motor nerves is believed to be reduced by removing facilitatory afferent input from the muscle spindles. And the procedure consists of stimulating spinal rootlets and monitoring EMG and motor function. These rootlets that are associated with an abnormal motor response are sectioned selectively, ideally treating the spasticity that the patient was painfully experiencing. Now, as far as anesthesia goes, we don't have to worry so much about other factors like propofol or gas as we do with SCPs, but we do have to pay a lot of attention to paralytics. So we use train of 4, which is a variation of a repetitive nerve stimulation, nerve conduction technique. And what we're looking for is the decrement between the first and fourth twitches. Again, 4 out of 4 twitches is preferred. Neuromuscular junction blockade below 80% provides nerve root stimulation thresholds similar to thresholds without blockades. Neuromuscular blockades or muscle relaxants completely block the polarizing actions of ACH, acetylcholine, at the neuromuscular junction. Common paralytics that you'll see in the OR will include things like succinylcholine, which will usually be used at induction. It's a short-acting depolarizing neuromuscular blockade. So it's going to depolarize all those muscles to fatigue. Our train of 4 is going to reflect that action by not having any kind of fade or decrement between our first and fourth twitches. The non-depolarizing paralytics, however, like our vecuronium, pancuronium, rocuronium, or even some of the older ones like atracurium and cisatracurium, will show a fade, a decrement response between the first and fourth twitch. So with train of 4, we're going to stimulate the nerve and measure the ratio of the first twitch amplitude response to the fourth twitch amplitude response. Depending on what kind of software or machines that you use, your output or your display may look very different, and the data that you get in return may also look different. But one thing that's going to be common is we're going to be able to measure these amplitude differences. So stimulation parameters are going to be at about 2 hertz, supramaximal twitch, which is approximately 25% above maximal muscle contraction, is obtained to ensure all nerve fibers are stimulating muscle contraction. It's important that we achieve supramaximal instead of just maximal stimulation, because if we're not stimulating all muscle fibers to contract, then we cannot verify that our fade or amplitude decrements in our train of 4 are due to the paralytic being on board, or if it's because of subpar stimulation. So brief little intro to interpreting train of 4. If we have 0 out of 4 twitches, then we know 100% of the neuromuscular blockade is working, so we have total paralysis. 1 out of 4 twitches is going to be around 95% paralysis. 2 out of 4 is going to show around 85% paralysis. 3 out of 4 twitches present will show 65 to 75% paralysis. And 4 out of 4 twitches present will show 10% or less satisfactory neuromuscular blockade recovery with a train of 4 ratio of greater than 0.9. Now, as far as artifacts, the EMG is going to be contaminated quite a bit with artifacts. And in many cases, we see more artifact than we actually see firing. So the artifacts can be caused by movement near the recording sites, electrode wires, head box, or cables. We also see SCP stimulation artifact in our EMG quite commonly, triggered stimulation or return electrode artifact, artifact from suctioning, from electrocautery. Our bovies and bipolars are also very common. Surgical instruments such as metal on metal touching inside the wound can cause very brief spike-like artifacts on the EMG. And then all the other equipment that's causing the OR to be such an electrically hostile environment, like lights, bear huggers, sequential compression devices, the bed, microscope, fluoro or X-ray, ultrasound, navigation, fluid warmers, arterial transducers, bovie grounding pads, surgeon loops, and headlights, even the remote that controls the bed. And then, of course, EKG as well will be seen. Every attempt should be made to identify the artifact, and if possible, correct the artifact that we see. Remember that sometimes the artifact may come from not just the devices, but the cords and cables that come from or that power the devices. And that can confound our troubleshooting abilities sometimes, because we can unplug a device and it will appear as if the artifact has diminished but not quite gone away. Some artifacts cannot be corrected, however, so this should always be documented. Activity in the free run EMG that is bilateral is typically artifact. So in conclusion, remember that knowledge of our anatomy is one of your most important tools. Knowing the nerve root innervations as well as the actual location of the muscles can get you through just about any procedure. Always remember that there are many more muscles that can be monitored. Never forget inter-patient variability. Not every patient is wired the same. Some patients may have muscles that have a primary innervation coming from a different nerve root, such as the FCU being innervated by C7 instead of just C8 and T1. This is reflected in literature by seemingly contradictory information sometimes. As a last resort, I always carry a copy of the Neurotechnologist Reference Guide. It's saved me a few times. It's not really an advertisement. I just really love this book. And thank you very much. Also want to thank the California Neurodiagnostic Society for having me.